सर
Look, okay. दीपा जी आप बिल्कुल ठीक हो रहे हैं. देखिए, just I'll explain you this patient. I've been seeing her for the last more than a decade. She's an interstitial lung disease. Initially progressed, then status quo couple of years, then progressed, then status quo. Again she worsened. Remember, whenever you have interstitial lung disease, remember I repeat it, whenever an interstitial lung disease presents with type 2 failure. Now, what is type 2 failure? When the carbon dioxide goes up, that means it is an end stage ILD. Will you remember this? So what happens? What happens in interstitial lung disease? Initially there is a fibrosis of the interstitial space. So lung goes into a volume loss, more volume loss, more volume loss, then work of breathing increases, lungs going into fatigue. So remember, throughout their life in interstitial lung disease, either they are hypocapnic or normocapnic. When they start building up CO2, that means they are going into a fatigue. You understand? This is a fatigue lung. It's not that you treat the infection, she becomes all right, because the lung fibrosis already has taken significant portion of her lung volume. And now, so I told you she got into lung fibrosis, there is a status quo. Then she has worsened, there is a status quo. एक मिनट रुक जाइए. Then there is a status quo, then there is a worsening of the lung disease, then there is a status quo. These are called progressive decline of the lung. Every decline of the lung loss, what happens? It causes increasing work of breathing. And as I told you, what is work of breathing? Load versus capacity. If the capacity is fixed, if the load becomes more, initially there will be, from hypocapnia will be normocapnia, then will be a hypercapnia. And you see the hypercapnia what she had yesterday. It was 105. Can you imagine? Now, if this patient would have been in any part of the world in ICU, people would have ventilated, mechanically ventilated. This is the decade of pulmonology where you have to use non-invasive ventilation judiciously. And I think this is an eye-opener. You read literature, you surf the literature across the world. Nowhere in the world you find the patient presented with type 2 failure 105, drowsy, significant work of breathing in this kind of lung. The first thing a person would have done is put her into mechanical ventilation. Did we do it? No. Why? Because when you understand the disease, because by putting her into mechanical ventilation, you would have made her into more complication, because mechanical ventilation has a lot of complications. They get dependent, because why they are having retaining carbon dioxide? Because their lung capacity is fixed. They are going to progressive lung loss. So once you put them in a big ventilation, they enjoy the ventilation and they get stuck up. So what we are doing here, we are just supporting the lung muscles. We are bringing a change in the pH. And you see from 100, don't you think it's a publication? We should publish this case. From 102, we have brought it to 79. And what did I tell you yesterday evening when Naren was there? I said, give her a high PEEP, more than 10, and give her a high pressure, and don't make her feed through, and make a very snugly fitting face mask. This is what we have done it. Suppose you would have disconnected the mask, what happened? There will be a leak, and leak would have caused a, discomfort, carbon would have gone up. So what you have learned, if you can manage lung fibrosis especially, or any kind of patients who comes with high PCO2, if this is the magic of non-invasive ventilation, which I tell you, this is the magic. And that's why non-invasive ventilation needs most critical monitoring. You have to see to it, there should not be any leak. So we ensured it. Why she has improved? Because you have given a full fast ventilation, adjust the ventilation, you have improved her alveolar ventilation, and she has improved. Now what you have to do? There are three things you have to do it. Please see to it that she should not be fed from here. Moment you dismantle the mask, there will be, the support of the lung will go up, so no feed, no fiddling around of this area. Number two, if you want to give any kind of nebulization, we'll give through side port. Okay, we have a connector. Please, please, please go through this video. If you want to learn pulmonology, please don't fiddle around with this interface. At least 48 hours till we achieve a desirable carbon dioxide, maybe 50s. We are not able to achieve 40s for her because her baseline is 50s. You have to go by the pH changes. You got it? Number two, give her nutrition, because if you cover her face, then she will not able to eat. So we will give slow TPN, slow nutrition. Number three, whatever the nebulization, everything, don't give anything through orally. If you really want to give anything through orally, put an IELTS tube. if you want to give any tablet. So I think let's hold the RALS tube even for a day. Tomorrow we'll put the RALS tube. So what we want to give, let's give us some nebulization, control her sugar through insulin control, give us some injectables and through TPN. And continuously give her non-invasive ventilation. Sister, mask nikalna nahi hai.
Yes sir, सुबह से नहीं निकाला.
Don't give her. If at all she's current, थोड़ा सा निकाल के फिर लगा देना. Because we have to target 50s. It's okay? So this is the whole management, and this is really, we have achieved it. This is called the good clinical team. Otherwise, what you would have done? Oh, sir, 110 ho gaya. Forget about it. Anesthetize, mechanical. Then you would have been in big machine. Then there are ventilation complications. There is a trachea problems. There is a dependence on ventilators. There is infections. So many complications of mechanical ventilation. So what you have learned? Non-invasive ventilation, if it's used judicially, and if you can hold the time and give adequate support, they can do well. This is my tag. So this you learn and you will share in that group. Okay?